Dr. Girish, we'll start.
Okay.
Yeah, just let me introduce you. So, good morning, everybody. As I have said, this is our last talk on vasculitis. The next will be on gout, and after that, our main topics of rheumatology we will be concluding. So, today's speaker is Dr. Girish Kakde. He has done his DNB rheumatology from Hinduja Hospital, Mumbai, and is now practicing as a consultant rheumatologist in Pune. So, Dr. Girish, over to you.
Thank you, madam, for the introduction. So I'll be talking about large vessel vasculitis, about the topic. So vasculitis. So vasculitis definition. We can say the definition is different for a pathologist and a rheumatologist. For a pathologist, it is inflammatory destruction of blood vessels. So we all know we already talked about the medium vessel and small vessel vasculitis, as far as I know. So this is the last talk on vasculitis, large vessel vasculitis. So we know vasculitis is inflammatory restriction of blood vessels. It is because of infiltration of blood vessels with inflammatory cells. It is called as leukocytoclasis, and elastic membrane disruption also happens. There is fibrinoid necrosis of vessel wall that leads to ischemia, occlusion, and thrombosis. And vessel wall destruction leads to aneurysm formation, rupture, and hemorrhage. So this is what pathologist sees in a pathological slide, histopathological slide, whenever they do, whenever we do the biopsy. And from rheumatologist perspective, it is a clinical diagnosis, clinico-pathologic process of characterized by inflammatory destruction of blood vessels, resulting in occlusion, destruction of blood vessels, and ischemia of the tissue supplied by that vessel. So symptoms of all vasculitis will be related to that particular vessel. So large vessel, medium vessel, and small vessel vasculitis will have typical pattern of clinical presentations because they supply blood to the typical organs. So the clinical picture is different. So we can categorize based only on symptoms and signs. We can categorize whether patient has large vessel vasculitis, medium vessel, or small vessel vasculitis. So in vasculitis, which blood vessels are affected? So any blood vessel can be affected because all blood vessels can get attacked by the inflammatory cells. So arteries, arterioles, capillaries, venules, veins, all can be affected. And it can damage virtually any organ or tissue because any blood vessel can be affected. But these three types of vasculitis, so large, medium, and small vessel vasculitis, will have different affection of these vessels, leading to different clinical presentation. So these are the groups of vasculitis. First is large vessel vasculitis that we are going to talk about. The two main vasculitis in this group are Takayasu arteritis and giant cell arteritis. Then there is medium vessel vasculitis, which has polyarteritis nodosa and Kawasaki disease, which is seen in children. Then we have small vessel vasculitis. Small vessel vasculitis is a big group. It contains ANCA-associated small vessel vasculitis. It contains three main, like granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, and microscopic polyangiitis. And there are other non-ANCA-associated small vessel vasculitis, like cryoglomic vasculitis, IJ vasculitis, hypocomplementic urticarial vasculitis, or anti-GBM disease. So depending on the size of the vessel, vasculitis is classified because clinical presentation is different of each group. And there is one small group called as variable vessel vasculitis. Main is Behçet's disease. So this can affect all the three types. So it can have large vessel vasculitis picture, can have medium vessel vasculitis picture, or small vessel vasculitis picture. Another vasculitis, Kogan syndrome, also can be considered as variable vessel vasculitis. Usually has large vessel vasculitis, but can have medium and small vessel vasculitis as well. So vasculitis, so what organs can be affected? As we already saw, any organ can be affected, and it can have varied presentation in different organs. So in nervous system, stroke usually seen in large vessel vasculitis. In heart, it is myocardial infarction, hypertension. In GI system, bloody stool and abdominal pain seen in medium and small vessel vasculitis. Joints can be affected in any type of vasculitis where there is pain and arthritis. Skin, so showing palpable purpura and livido reticulitis is seen in medium and small vessel vasculitis. In eye, there are different conditions which can like vasculitis can affect eye in different ways, leading to reduced visual acuity. In nose, there can be bleeding. In lungs, bloody cough, that is hemoptysis, and lung infiltrates, usually seen in small vessel vasculitis. In kidneys, glomerulonephritis, again small vessel vasculitis. In muscles, there is pain. And general symptoms are common to all the vasculitis: fever, headache, and weight loss. So general systemic symptoms can be seen in all the vasculitis. This has to be kept in mind because the patient with PUO, that is pyrexia of unknown origin, if infection and other things are ruled out and malignancy is ruled out, then we'll have to think about vasculitis as a differential diagnosis. So then I spoke that the clinical manifestation of large, medium, and small vessel vasculitis is different. And we can actually group a patient into a typical vasculitis depending on the clinical feature. So here we are going to see how. So in large vessel vasculitis, today's topic. So because large vessel is involved, the involved organs are big, like limb claudication, whole limb claudication, upper limb, lower limb claudication. Claudication means whenever there is pain on doing activity. Suppose there is claudication in the leg. So while walking, after walking some distance, patient feels pain and he has to stop. And in arm, after doing some activity, patient has to stop because there is pain in the arm. So limb claudication is important symptom. Asymmetric blood pressures, because there could be asymmetric affection of the big arteries of the arms. It could be the patients could have asymmetric blood pressures. If patient is not treated in time, there could be absence of pulses. This is what we want to actually avoid with treatment, so that patient doesn't go into this stage. Bruise, when the diameter of the blood vessel goes down, the blood flowing causes bruit, aortic dilatation, and renovascular hypertension. These are the manifestations of large vessel. Whereas in medium vessel and small vessel, manifestation is slightly different. In medium vessels, skin involvement can show cutaneous nodules, ulcers. So leg ulcers, chronic leg ulcers can be a manifestation. Medium vessel, livedo reticularis, digital gangrene, mononeuritis multiplex, microaneurysms, and renovascular hypertension also here can be seen. In small vessel, the skin shows purpura, urticaria, vesicobullous lesions. Glomerulonephritis, alveolar hemorrhage are the big serious manifestations of small vessel vasculitis. And cutaneous splinter hemorrhages, uveitis, episcleritis, scleritis. So they are small vessel vasculitis because they are having small vessels there. So we will stick to only large vessel vasculitis. So in large vessel vasculitis, we mainly have giant cell arteritis, which is also called as temporal arteritis, and another is Takaisu arteritis. So temporal arteritis is because the temporal artery can get affected. That's why it's called temporal arteritis. So this usually affects temporal artery, but this can also involve ophthalmic artery and other arteries of the brain. So, and Takaisu arteritis is usually the main arch of aorta or branches of aorta can be affected in Takaisu arteritis. So what is the difference between the two? What are the similarities? We will see. So in temporal or giant cell arteritis, the superficial temporal artery is usually affected. It is a large vessel vasculitis. So what are called as large vessels? So aorta itself is large vessel, and main branches of the aorta, the arteries coming directly from the aorta, are called as large vessels. So large vessel vasculitis, it is a type of large vessel vasculitis. It is vasculitis of unknown cause. So almost all vasculitis, we do not know the exact cause. In at least ANCA vasculitis, we have the antibody. ANCA antibody is there, and we can say that has some pathological role. But in these type of artery, giant cell and Takaisu, we do not have any antibody. We do not exactly know the cause. It is focal granulomatous inflammation in both. So this is common in both the Takaisu and giant cell. It is granulomatous inflammation. But the difference is in temporal arteritis, usually elderly female, typically seen in patients more than 50 years of old. So it is highly unlikely to see temporal arteritis in patients below 50 years of age. So if you have large vessel vasculitis, patient's age is below 50, more likely the patient has Takaisu arteritis. If the age is more than 50 and patient has symptoms of large vessel vasculitis, likely patient has giant cell or temporal arteritis. The role it is affected more in women, 2:1, than men. And temporal arteries are more commonly affected, but other arteries, even aorta, carotids, and other branches of aorta also can be affected, but it's less common than Takaisu arteritis. It is associated with increased risk of aortic aneurysm and aortic dissection. What are the clinical features? The patients, as I said, all vasculitis patients will have some sort of systemic symptoms like fever, fatigue, weight loss, malaise. So these are the common to all vasculitis. They're also seen in large vessel vasculitis as well. It's more in giant cell arteritis. In Takaisu arteritis, we may not see these many symptoms. I mean, one of the most important symptom of Takaisu arteritis, temporal arteritis, is headache. Usually, it is temporal headache. Usually, it's ipsilateral, but can be bitemporal as well. And then jaw claudication. because of it is like anginal pain. So whenever patient choose is having food, there is pain in the jaw after some time. And the dreaded complication of temporal artery is visual impairment. It can be seen in 25 to 50% of patients. It can lead to transient vision loss, and if not treated urgently, it can lead to permanent blindness. It is caused by involvement of ophthalmic artery occlusion and sometimes optic neuritis of amaurosis fugax may lead to blindness in up to 50% if not treated early and aggressively. So this is the complication which we are very afraid of in temporal arteritis, because this can leave patient totally blind for rest of his life if not treated in an emergency. So this is one of the rheumatological emergencies. Rheumatoid emergencies, this is visual impairment in a giant cell arteritis. Okay. And 40% of this temporal arteritis patients may have polymyalgia rheumatica. So what is polymyalgia rheumatica? It is associated conditions where patients have shoulder girdle or pelvic girdle stiffness, early morning stiffness. There is pain and seen in more than 50 years of age. ESR, CRP are high. So polymyalgia rheumatica, we can say the spectrum of this disease, milder spectrum. So patients can have polymyalgia rheumatica without having temporal arteritis. And temporal arteritis patients, some patients may have polymyalgia rheumatica. Polymyalgia rheumatica is a milder disease which needs lesser dose of steroid and usually gets better earlier. Temporal arteritis is a severe form of disease which needs higher doses of steroid and longer treatment. How do you diagnose temporal arteritis? So basically, the diagnosis is suspected based on the clinical symptoms. When a patient more than 50 years, maybe 60, 65 years, comes with temporal headache, which is new onset headache is very important, and which is not getting relieved with anti-inflammatories. When there is jaw claudication, when patient has systemic symptoms, has lost weight, so then we suspect that patient might be having temporal or giant cell arteritis. So first investigation that is important is ESR. So if we do ESR and along with this CRP is also important. If these inflammatory markers are elevated, the chances of having temporal arteritis go very high. And if typical clinical picture with high ESR CRP, patient should be treated with steroids before we can do investigations, we can do ultrasound, and we can do these things, but we should not wait for the reports to come back if the clinical picture is totally supporting the diagnosis. So normal ESR does not exclude the diagnosis. This also has to be kept in mind. Next step would be the point is missing here. The next step would be, now it is available easily. We can do temporal artery Doppler. So that temporal artery Doppler can show typical halo sign, the inflammation around the blood vessel, and that will actually diagnose that will give us the definitive diagnosis. Biopsy in some cases, when the temporal artery Doppler is negative and we are strongly suspecting temporal arteritis, or sometimes when the Doppler is not easily available. In those cases, biopsy of temporal artery can be done, which has good sensitivity of 90%. But thing has to remember, even temporal artery biopsy can miss 10% of the patients, especially because temporal arteritis can have skip lesions. So we need to, even if there is a possibility we may biopsy the normal lesion, and there may be the other lesions having vasculitic picture. So single negative biopsy does not exclude the diagnosis. So this is a very tricky diagnosis, temporal arteritis, in case of patient has typical picture, normal ESR, and maybe biopsy is normal. You have to keep in mind, and you have to sometimes you have to treat with clinical suspicion that patient might be having temporal arteritis. But those cases are very rare. Usually, we will find something either in blood investigations, either in Doppler or a biopsy. So depending on these three, we usually have the diagnosis. Sometimes we need aorta imaging also, maybe CT aortography. In case of, I'll see one of the patients had I have cases at the last, one of the patients had similar symptoms, and actually aortic imaging clinched the diagnosis. So keys to diagnosing temporal arteritis is age more than 50, new headache. So any person having more than 50 age with new headache should be suspected temporal arteritis. So we as a rheumatologist in India see less numbers of temporal arteritis as compared to our counterparts in Western countries. When I was in UK, we used to see very high numbers of temporal arteritis. But maybe one of the reasons is because patient's main symptom is new headache. Neurologists must be the one who will be seeing most number of patients, and they might be the diagnosing these cases and treating. So as a rheumatologist, we see less number of patients, but still we should be aware that more than 50 years, new headache, this could be temporal arteritis. We have to palpate temporal artery. If there is palpable or tender temporal artery, then chances of temporal arteries are very high. With high ESR jaw claudication, this you can say that patient is high likely to have temporal arteritis. So this is in one slide, we can say that giant cell arteritis in short, it affects aorta and its large branches, especially external carotid arteries, temporal arteries, vessels of head and scalp, superficial temporal artery, neck and jaw pain, vision loss, which we want to prevent, tender and temporal arteries. There are positive signs of systemic inflammation, fatigue, fever, weight loss, more common in more than 50 years of age, 50 to 55 years age, may be associated with polymyalgia rheumatica, and complications that we want to avoid, aortic aneurysm, stroke, blindness. So this you can see the palpable temporal artery in a giant cell arteritis. This picture taken from the internet. So what is the treatment for temporal arteritis? There is good treatment available for temporal arteritis. We have to start with high dose corticosteroids, even prior to doing temporal artery biopsy or whatever investigation we want to. If temporal artery Doppler is easily available, then yes, in same day if you can get it done, then it can be done. But if it is not easily available, if the patient has to travel to other place or there might be some delay in investigations, you can start corticosteroids in the dose of maybe 1 milligram per kg, because that is the standard dose. Later, if the diagnosis is disproven that the patient doesn't have temporal arteritis, then you can stop the steroid. Only thing if you have to take in mind is whether patient has diabetes or blood pressure, that things to be monitored. Then after treatment, we can follow up ESR level to monitor effectiveness of treatment. If ESR is high at baseline, then after treatment, ESR will go down. Treatment usually lasts for 2 to 3 years, minimum 1 year to 2 to 3 years. The corticosteroid dose is tapered slowly. Many patients, we also add additional immunosuppression like methotrexate, so that corticosteroid dose can be lowered easily. It is usually self-limiting. All the vision loss may be caused. Once that treatment is done, we can stop treatment maybe after 1, 2 years or 3 years. It may not come back. But only thing is, during that episode, patient might have vision loss that we want to prevent. So vision loss in one eye may be temporary or permanent, and we need aggressive steroid treatment. Even need IV pulse steroid for 3 to 5 days to save that eye, whichever eye is having vision loss. It is primarily given to the to prevent involvement of the eye, but may also improve visual outcome in the affected eye as well. So these patients usually go to the ophthalmologist with vision loss. The ophthalmologist diagnose these patients having vision loss because of some vasculitis, and they start the steroid and they refer patients to rheumatologist. So next important large vessel vasculitis is Takayasu arteritis. It is most common in young Asian women. So below 40 to 45 years age is the common. So that is the age of presentation, and is seen in Asian women, Japanese and Indian women is very common. Takayasu arteritis we see very commonly in India. So again, it is a granulomatous vasculitis of aortic arch and its major branches, leading to fibrosis and potentially causing stenosis and narrowing of arteries originating from the aorta. This is what we want to prevent, stenosis and narrowing. So this disease is also called as pulseless disease, because many patients who are not treated, not identified initially and not treated, they eventually develop stenosis of their brachial and radial arteries, and then pulse is not identified, and the patient, you can say it is pulseless disease. But that stage we want to prevent with treatment, and diagnosed by our arteriogram, either CT or MR angiogram. So clinical features, again, constitutional symptoms are same: fever, night sweats, malaise, arthralgia, fatigue. But not all patients will have this. Many times we see patients are incidentally found out to have Takayasu arteritis. They go to their physician for routine checkup. The physician finds out the pulse is not palpable or the BP is different in both the arms, and then they refer for further evaluation. The patient do not have any symptoms. So because Takayasu arteritis is usually a slow disease, the body actually gets used to it. There are collaterals which are developed, and patients may not have any symptoms. And constitutional symptoms may be absent in Takayasu arteritis. There is pain and tenderness over involved vessels, maybe carotid arteries or something like that. Absent pulses in carotid, radial, ulnar arteries, aortic regurgitation may be present. Signs and symptoms of ischemia usually develop in areas supplied by involved vessels. If the upper limb arteries are involved, subclavian arteries involved, then patient may have claudication in upper arm. If lower limb arteries are involved, then the claudication symptoms mean the legs. Severe complications include limb ischemia, aortic aneurysms, aortic regurgitation, stroke. Young stroke, we have to always think of Takayasu arteritis, among other conditions. Secondary hypertension due to renal artery stenosis. This is very difficult. So if renal artery stenosis develops, this hypertension is very difficult to treat. Sometimes it needs the procedure to correct the renal artery stenosis. The main prognostic indicator is presence or absence of these complications. Once these complications set in, The immunosuppression treatment may not change the picture much, but we have to arrest the progress. But we have to prevent these complications by starting treatment, identifying the patient as starting treatment at early age. It can also cause visual disturbance. It is usually in the late stage with ocular involvement and hemorrhage of retinal arteries. Usually because of hypertension, uncontrolled hypertension, visual disturbances can occur in Takayasu arthritis. So in Takayasu arthritis or pulseless disease is a granulomatous disease, aorta and large branches affecting thickening and fibrosis of vessel wall, which narrows the lumen and it causes pulseless disease, weak or absent pulse, different pressures in upper extremities. So in Takayasu arthritis, you have to take all four limbs, BP, blood pressure, so that we can check whether there is different pressures in the limbs. Claudication in limbs, chest pain, syncope or pre-syncope, and hypertension because of renal artery stenosis. Non-specific symptoms are seen in all. Complications which we want to prevent is aneurysm, aortic regurgitation, and retinopathy, and most common in women in less than 40 years in Asian countries. The Takayasu diagnosis needs angiographic, usually needs angiography. Sometimes if patients have already lost the pulses, the diagnosis is clinical. But before that, it needs some imaging, usually CT angiography, CT aortography, or MR aortography for visualization of aorta and branches, which will demonstrate vessel narrowing. CT aortography is a good investigation at the beginning because it will show all the stenosis, which narrowing is also present, as well as vessel wall thickening. In follow-up, we can do MR angiography to prevent any more radiation exposure. Okay. So here we can see the affected arteries in this dilated ascending aorta. Similarly, renal artery stenosis we can see here in this angiography. So renal artery stenosis. So it is very common to have bilateral renal artery stenosis in Takayasu arthritis, which has very severe hypertension. So treatment again for Takayasu arthritis, we have to start with high dose steroids and which are tapered later. We add second immunosuppressant, usually methotrexate, azathioprine, or mycophenolate, along with steroids from the beginning, so that steroids can be tapered later on. And if possible, we try to stop steroids totally. Along with that, hypertension has to be treated. It has to be kept under control. Sometimes, rarely, surgery and angioplasty may be needed to recannulate the stenosed vessels. Because if the patient has already developed stenosis and which is not getting corrected, stenosis will not be getting corrected with immunosuppression, so that will need some surgical correction. So in Takayasu arthritis, Asian females in younger age, even young girls also we see constitutional symptoms, arterio-occlusive symptom, claudication, arthralgias, myalgias may be present. Examination shows blood pressure discrepancies, pulse deficits, arterial bruise, elevated inflammatory markers, ESR, CRP, but sometimes these can be normal despite patient having ongoing inflammation. Chest X-ray is rarely chest X-ray will show. Usually we'll see CT or MRI, which will show wall thickening and narrowing of lumen. So we need either CT or MRI angiography, MRI aortography. Treatment is systemic glucocorticoids along with methotrexate, azathioprine, or mycophenolate. This large vessel vasculitis like GCA will present as sudden blindness in secondary to anterior ischemic neuropathy or retinal vasculitis. Here we can see here. And Takayasu arthritis can cause hypertensive retinopathy or Takayasu retinopathy characterized by ischemia of optic disc leading to gradual loss of vision. So sudden loss is seen in GCA, gradual loss of vision in Takayasu arthritis. We'll see few cases, typical cases which present like these two. So 62 years old male presented with complete sudden onset painless vision of loss in the left eye. He had a complaint of jaw pain for last 6 months and pain in shoulders and hips. So these are symptoms, pain and shoulders that I was talking about. So these are symptoms of polymyalgia rheumatica, pain in shoulders and hips for 1 month. Eye examination showed changes consistent with acute ischemic optic neuropathy in the left eye. And ESR was high, ESR was 110. And our temporal artery ultrasound showed characteristic halo sign. So he had lost vision in left eye. So this vision loss, because he had complete vision loss, he did not actually gain any vision. But if he had come early, this vision could have been saved because he had symptoms, ongoing symptoms for 6 months. 22 years old female presented with complaints of new onset hypertension. So young patient with hypertension has to be suspected to have Takayasu arthritis. So anybody below 40, 45 years, if having hypertension, we should check all the pulses, whether any pulse loss is there. We should check both the arm BP, whether there is any difference in the BPs. We should check for bruit, carotid and temporal, carotid and subclavian bruit or renal artery bruit. And we should at least get basic investigations done like renal artery, Doppler, and ESR, CRP, along with other investigations. So new onset on hypertension and upper limb claudication symptoms she had. Routine investigation showed high ESR and CRP, and she also had bilateral renal bruit. CT autogram showed focal thickening occlusion of right subclavian artery and bilateral renal artery. So diagnosis of Takayasu arteritis because she's just 22 years old female. So, so she was started on steroid and methotrexate, and so she did well. 46-year female presented with complaint of neck pain, dizziness. Routine investigation showed absent right radial pulse and right side carotid bruit. 2D also had moderate AR. There was thickening of right common carotid artery and occlusion of right radial artery. So even though she is 46 years female, her symptoms were ongoing for few years. So this was Takayasu arteritis or not giant cell. So to keep high degree of suspicion of underlying vasculitis when there is absent pulse, BP difference among both upper limbs, aortic regurgitation, carotid bruit, MI also, stroke and MI in young patient, we should suspect vasculitis. Unexplained myocarditis. So monoitis multiplex usually seen in medium and small vessel vasculitis. So distal sensory neural peripheral neuropathy can be seen in medium and small vessel vasculitis. Stroke in young. So MI in young and stroke in young should be suspected to have some type of vasculitis and should be evaluated. Sudden onset blindness, complaint of recurrent dizziness, syncope, and neck pain. These are all large vessel vasculitis symptoms and myelopathy. There's again one more case. Yeah, so 26 years male. In 2017, he had bilateral hearing loss, diagnosed as Meniere's disease by ENT. No treatment details were available, only one prescription saying he has Meniere's disease. 2019, he had acute transverse myelitis, was treated with steroids, IVIG, and MMF, got better partially, but stopped the treatment and did not follow up. At that time, few papers showed that he ANA and ANCA was negative. In December 21, he had acute chest pain, one episode of fever, and found to have accelerated hypertension. The BP was very high, got admitted under a cardiologist. His investigation showed high ESR and CRP. So CT aortography was done. Young male with accelerated hypertension and high ESR CRP. CT aortography was done, which showed diffuse wall thickening of aorta and its branches, infrarenal abdominal aortic aneurysm. So there was aneurysm also was there. He underwent CTPA to D other investigation as per the cardiologist advice. Showed mild pericardial effusion. His viral markers were negative. Repeat ANA blot, ANCA, these were already sent prior to CT aortography report. Were negative, APLA workup. Did not have any orogenital ulcers, so did not have any symptoms suggestive of Behçet's disease. He was diagnosed as large vessel vasculitis based on the CT aortography report. Previous history of very Meniere's, only one prescription saying that, and history of transverse myelitis. So possibility of Kogan syndrome was thought because he had ENT symptoms and large vessel vasculitis, but he did not have any eye symptoms. So this could not be confirmed. Patients can have incomplete Kogan syndrome also as well, but we don't know. So this patient definitely has large vessel vasculitis. Treatment wise, it will be the same. So Kogan syndrome is, as I said, is one of the variable vessel vasculitis. Behçet syndrome and Kogan syndrome, they can have large vessel, medium vessel, or small vessel presentation. So this patient had large vessel vasculitis. We cannot officially label him as Kogan syndrome. This is only just the thought that came up. He was treated with IV methylprednisolone followed by 1 mg per kg steroid and methotrexate, which was later on increased. And currently he is off steroid on methotrexate, and that aneurysm that is there, it has actually got better. He's under care of a vascular surgeon and he doesn't need any procedure. So last 3 years he's been following up without any intervention being needed. So this is just a picture. This is not from this patient, another from internet. Interstitial keratitis in Kogan syndrome. If this was there, then this patient would have fulfilled Kogan syndrome definition. Next case, 65 years female. She had a 3 months history. So she had main symptom was fever. On and off fever she was having, significant weight loss, no localizing infective symptoms, and no headache. She did not have any headache, no, only fever and weight loss. These are the main symptoms. She visited multiple physicians, even went to the oncologist because fever and weight loss was there. Physician referred her to oncologist to rule out any malignancy. Her labs had anemia, leukocyte, thrombocytosis, ESR, CRP were very high, more than 100. LFT, RF were normal, cultures were negative. So oncologists advised PET scan to rule out malignancy, and it showed diffuse wall thickening and FDG uptake in thoracic and abdominal aorta. No other active metabolic lesion was found. So this was giant cell arteritis, which is called giant cell arteritis, large vessel vasculitis type. So this patient did not have temporal artery involvement, but had aortic involvement. So this is small group of patients of giant cell arteritis where they have these systemic symptoms without headache and high ESR/CRP. PET scan was diagnostic in this. Then she was treated with prednisolone along with methotrexate, and she got completely better. ESR/CRP normalized, symptoms completely got better, and she's off steroid on only methotrexate. So we have to also think of major categories of mimics of vasculitis. So whenever we have patients suspecting to have vasculitis, we have to think about other diseases which can present as vasculitis. So infectious causes, infective endocarditis, we have to think about that, hepatitis, viral markers, hepatitis B, C, HIV, atherosclerotic, especially in giant cell arteritis, temporal arteritis. It is very difficult sometimes to differentiate between atherosclerotic aortic involvement and inflammatory giant cell arteritis involvement. You have to use clinical acumen. Inflammatory markers sometimes will help us, and talking to radiologists will help us most. Thromboembolic diseases, congenital diseases, hereditary disorders, they are less common. Fibromuscular dysplasias in young people, hypercoagulable states like antiphospholipid syndrome, then other multisystem inflammatory disorders like sarcoidosis, Suzanne syndrome, malignancy. So in giant cell arteritis patients, we have to always think about malignancy because systemic symptoms are common. Like this, the last patient, the patient only had systemic symptoms. The main concern was whether patient having some malignancy. And iatrogenic because of post-radiation therapy, IgG4 related disease. This can also mimic vasculitis. Thank you.
Thank you, Dr. Girish. That was an excellent talk. I think this topic is very important for physicians because most of these patients reach physicians for PO,
Yes.
especially giant cell arteritis, polymyalgia rheumatica. They will be picked up by physicians and then referred. And very important is to rule out all the infectious mimics
Yes.
before giving the patient immunosuppressants.
Yes.
Uh, any questions by the audience? Anybody would like to ask any questions, you can add to the chat box. And as one thing that Dr. Giri said, some key messages are not to wait for the biopsy report and when you are suspecting a giant cell vasculitis with eye involvement. We cannot wait for us to get a biopsy or prove it by a biopsy or a Doppler. If the clinical suspicion is high enough, then we should be able to treat because otherwise the vision loss will be permanent and irreversible.
Few days of steroids are not going to do any much damage to the patients if we just
Absolutely,
monitor steroid,
absolutely,
monitor the sugar.
absolutely.
But if we miss that window, patient may have permanent blindness.
Yes, absolutely. And we can decide about the long-term treatment later, but at least initial treatment with steroids would be important. So I think there are no questions. Thank you, Dr. Girish. That was an excellent talk, very informative.
Thank
1 minute. There is one question. 1 second. Difference between migraine and temporal arteritis headache. Dr. Girish, would you like to answer it?
Yeah. So usually migraine we see in younger females, younger patients. They are having the headache usually going on for many years. The younger population, and temporal arteritis headache is usually seen in older population. So in older population, new headache which is coming up. We don't suspect migraine in those patients. So so the difference is that age is different, and migraine is history will be there from like maybe childhood or younger age, and temporal arteritis headache comes up suddenly in
Right.
patient.
And so it would be a headache which like the patient has never got before.
Yeah. Yes.
It's a very different sort of headache, and many times patients with temporal arteritis headache get admitted because the headache is so severe. And then, of course, afterwards, when you see the
Yeah,
inflammatory
migraine
markers
also.
are high.
Yeah, migraine can get better with naproxen or something like
Yes,
inflammatory medicines, but temporal arteritis headache will not get better until and unless we start steroids.
yes, right. So I don't think there are any other questions. So we can close today's session. Thank you, everyone, for attending. Thank you, Dr. Girish. Thank you
Thank
so much. Have a good day, everyone. Bye bye.
Não, porque aí é